Cloud. Welcome everyone to another installment of the World AIDS Museum and Educational Center's Spotlight series with Andy Ruffner, who is our Director of Education and Programming, and myself, Dr. Raquel Lopes, acupuncture physician and Executive Director. I forgot who I was, Executive Director for the World AIDS Museum. And we are lucky enough to have this week Dr. Lynn Mofenson. And I'll read a little bit about her because you will want to look her up. Dr. Mofenson is among those who played a pivotal role in curtailing the deadly epidemic among children, and is a physician who used to work at the National Institute of Health, who helped design and conduct the seminal pediatric AIDS clinical trial, and has since dedicated her career to conducting additional research and influencing national policies in this field. And even today, she works for the Elizabeth Glaser Pediatric AIDS Foundation and focuses on ensuring that children around the world are able to live healthy lives. I want to welcome you, Dr. Mofenson, to our conversation this week.
It's a pleasure.
Thank you. So we usually start off this conversation by asking, how did you get involved, or how did you find yourself in the field of HIV?
Well, it's kind of a long story, and it goes back to 1977 when I was an intern, a pediatric intern at Boston Children's Hospital. And I admitted to the ward. My first ward admission was a young kid, about 3 months old, failure to thrive, multiple infections, and an immunodeficiency of unknown etiology. His parents were intravenous drug users. No one knew about HIV then. He had what we then called low E rosette cells, which is CD4 cells. And he was, no matter what we did, he didn't get better. And he was actually my first patient as a physician who ever died. And that kind of really marked me. And we had no idea what was wrong with him. And if you then move forward to 1982, when Gwen Scott and Jim Molesky began to write about the first kids with HIV, and I read their descriptions, I realized that this particular child and all of the symptoms he had and all of his findings on autopsy matched that, and he may actually have had HIV. So even before I knew what HIV was, it was kind of like I needed to be able to help kids that were like this. After my residency, I worked as an infectious disease physician for a while in Massachusetts and began to care for some of the first young men with HIV who had, for example, pneumococcal sepsis and died, and the HIV test wasn't available yet. I moved then to the health department, the Massachusetts Health Department, where I directed their infectious disease programs just at the same time the HIV test became available, 1985. And we set up what we called the first alternative testing sites, where people could go and get an HIV test anonymously, without their name, without having it marked down. And I would say a lot of what we did then was actually discouraging people from getting tested because there were no treatments available. Then I moved to NIH in 1989. And when I started at NIH, I moved from doing general infectious diseases to just HIV. And an example of what HIV was like then in 1989 was that I worked a little bit on the inpatient wards at NIH with Phil Pizzo's group. And we had a little girl with pretty much every complication of HIV who ended up also dying despite multiple treatments. And the AIDS quilt was available on the mall in Washington, DC. And I brought my husband and daughter to see the mall and the quilt. And the first quilt we came upon was for this little girl. And so that was what HIV was like then. It was, a infection that people didn't understand how it was transmitted. We didn't know how to treat it. No matter what we did, people were dying, and in particular kids. And so for me, it became really my life's work to be able to fix it, and kind of to be able to do something that would make that first patient of mine who died not die. And so that's really how I began to work in HIV.
Wow, that's an incredible. I can use this for future education programs on teaching about the early stages of this, because I think that's one of the things that comes up a lot here at the museum is that we were debating about how to start our chronology exhibit, because we date the chronology from 1981 with the publication of the various articles where we're talking about the Morbidity and Mortality Weekly Report, or tomorrow, there's another anniversary here with the New York Times article that came out in July of 1981. And then I think it's so important, though, to tell people that, this didn't just appear. There were people who had this disease prior to that, and so it's so interesting to hear this perspective about, it's 1977, I'm seeing something, and then carrying that all the way through, not having a test in that. So I'm curious about what your thoughts are about, how do you balance this like physician and advocate role in this? Because it wasn't just being a physician that you had to be, right? I mean, so you took all these leadership roles, ultimately ending up with the national, I'm trying to make sure I remember this, the National Institute for Child Health and Development in that. So you ended up being a spokesperson. How did that happen for you to, become a leader in it?
Yeah, it's not, I'd have to say it's not something that I had planned out. And it was really more not like I was going to be a leader. It was that I was doing things and other people weren't. And there was like this hole. So people were, paying a lot of attention to young gay men with HIV, but no one was paying attention to kids. And so when I moved to the health department, that was where my attention went, and beginning to set up policies for school attendance. So back then, people wouldn't let kids with HIV into school. In Florida, actually, the case in Florida where they burned down a people's house after the court said that they needed to. So I filled that hole by helping to develop policies for school attendance and daycare. And so it was usually that there was this hole that wasn't being filled, and I felt like it needed to be filled. And the same thing when I went to NIH and was seeing, all of these kids die. Treatment was available for adults, 1987 with AZT, but nothing for kids. Mm-hmm. And mother to child transmission was occurring, but there was no way to prevent it. So it seemed like that was a hole that needed to be filled. So we worked to set up a clinical trials group that worked with NIAID to be able to do drug studies in kids, to be able to do prevention of transmission studies. And so it was never like an intention. It was just always that people weren't doing anything about something that I thought needed to be done. And so that's what I did.
That's what you do. That's what you do. Yeah, no, I think that's really, but this is a really important thing for people to kind of understand about finding yourself. Did you realize at that point that you were in history?
No, actually, it's really strange. It's only retrospectively that you see the progress. And while you're doing it, I can remember when I was first at NICHD, and there was a lot of infighting over who's going to do what clinical trial and where money was going to go. And I would say to myself, I just don't want to do this anymore. It's just, terrible. It's stressful. And I would keep doing it. And then, 10 years later, you can look back and say, oh, well, that thing that I did then really made a difference now. But it's only retrospective. And while you're doing it, it feels hard, difficult, and discouraging. And so, I think you just have to stay in there, keep plugging, and then be able to look back and say, what did I do that made a difference? And so it was like that. I was very discouraged most of the time early in my work.
Well, we are always thankful that you continue the work that you did because, we had Dr. Scott on several months ago, and she talked about the study that you referred to, the 076 study. And your team were part of the collaborators to bring that forward. And I just wanted you to talk a little bit about that because that was a game changer for the time.
Yeah. So it was an interesting period, and I can't take credit for it. This was a multi-person study that involved people from NIAID, NICHD, all of the people at the sites. And what we had was AZT became approved in 1987 for treatment of adults. And as we went on, we realized that more severe disease and the virus in the blood in the mother was associated with transmission to the baby. We knew that transmission occurred from mother to child. We didn't know if it was during the pregnancy or intrapartum or both, and the proportion. And it seemed logical that if you could give a drug that reduced the amount of virus in the mother's blood, that there would be less virus to get to the placenta, less virus in the mother's vaginal secretions, and that should theoretically decrease mother-to-child transmission. So we got pediatricians and obstetricians to talk to each other, which at that time was unusual, and developed the design for this trial where we would give AZT to the mother during pregnancy, during labor, and for a short period to the baby. And it was a kitchen sink approach since we didn't know exactly when there was transmission. We gave drug during pregnancy after the first trimester to prevent transmission that might be in utero. We gave drug intrapartum to the mother, which got across the placenta to the baby and provided pre-exposure prophylaxis to the baby so that the baby had drug on board as it was going through the vagina and being exposed to secretions. And then we gave drug to the baby for a short period after birth as post-exposure prophylaxis in case the baby had swallowed any virus, for example. So that's what we did. Now, doing this trial was highly controversial. The FDA had to hold a public hearing. People thought that we were poisoning pregnant women by giving them this drug. But we moved forward and did the trial. Gwen's site was an important site of enrollment. And it was February 1994, President's Day weekend. The DSMB met on a Friday and told us the drug is, 70% effective in reducing transmission from, and that you should stop the trial and tell everybody, put everybody on AZT. Completely unexpected, the amount of efficacy. And it was very interesting. It initiated the first rapid communication. So we found out on a Friday, and we're working through the weekend to notify the investigators so that they would take their patients on placebo and put them on AZT. And on Sunday, the LA Times broke this story. We didn't have time to even tell our investigators.
Wow.
That's the way things are today. Everything's by press release rather than publication. So the trial itself wasn't published until November. But here we were in February, LA Times. And so I was asked to chair a public health task force to develop recommendations from this trial. And within 2 months, by April, we put out preliminary recommendations through the MMWR, the CDC, to all the health departments that pregnant women who had CD4 counts over 200 should be put on AZT to prevent transmission. And by August, we had put out final guidelines on prevention of transmission using AZT in women, regardless of their CD4 count. And that was probably the most rapid set of guidelines that I've ever been involved in developing. And within 3 years, we had decreased transmission in the US by 60%, within 10 years by 88%. And currently we've gone from, in the US, about 2,000 infections a year at peak to maybe 50 or less currently, initially with AZT, and then of course as treatment improved to using combination drugs. So in retrospect, it was a very exciting time and made a big difference. But while it was happening, as I said, it was very stressful.
I can imagine. For those who are still learning about vertical transmission, can you explain the 3 ways? I mean, prior to us getting on, you were talking about that. And I think that's really important for people to understand how the transmission happens between mother and child.
Sure. So as everyone knows, HIV is a virus that's in the blood. And in a pregnant woman, the blood goes to the placenta and through the placenta to the fetus. So the virus can go through the mother's blood, particularly if there's a lot of virus, and infect the cells in the placenta, and that can move to infect the cells in the fetus. So that gives you transmission in utero occurring during pregnancy. But also, mother has virus in her vaginal secretions. This is a sexually transmitted disease. And so during labor, if the baby didn't get infected in utero, during labor, the baby goes through the vaginal canal, is exposed to those secretions, and can be infected intrapartum. So that's the second way. And then the third way is that the virus also gets into breast milk. And so in breastfeeding women, if they're not on treatment and they've got viremia, that virus can enter the infant and actually infect the infant's tonsils, the GI tract, and go on and infect the infant. So there's 3 ways. One is in utero, intrapartum, and through breastfeeding. And how does antiretrovirals work? Well, antiretrovirals work by making it that the mother doesn't have that virus in her blood. So therefore, it doesn't get into the vaginal secretions. And it doesn't get into, or it gets into very limited way, into the breast milk. And so that's the primary way that antiretrovirals work. But there is a secondary way, and that's that drug that you give to the baby, providing pre and post-exposure prophylaxis. Because even in women with a very low viral load, you can still see some transmission, but that can be alleviated through giving the baby that 6 weeks of AZT. So that's kind of the way that the drugs work to prevent transmission during these time periods.
Thank you for that, because I think that there's all that sometimes misinformation out there about, and we had this in our educational program where we'll have youth ask whether it is genetic or inherent, hereditarily transmitted. And so, the kids are now asking some more detailed and in-depth questions, which is great. And being able to make sure that they get the most proper information is always important. So I appreciate that. But it leads me to, I think Anna is jumping to get to his question. But I want to say that it leads me to the conversation about this particular study being so successful that it ended early. So it worked in the United States, and it plummeted the numbers of mother to child transmission so significantly. And yet outside of the country, there were still rates of infection that were alarming. And it wasn't until later that even what we've done in the United States was even offered other
Yeah.
places. And
Yeah.
can you tell me about your interactions with that?
Sure. So actually, almost right after the 076 trial became available, the World Health Organization called an international meeting in Geneva of people from all different countries in Africa and the researchers to discuss the results of 076 and to discuss whether that should be implemented or whether there should continue to be placebo-controlled trials. Because at that time, there were several trials that were developed looking at short course AZT. So I want to stop and say the 076 regimen started at 12 weeks gestation. It was given, AZT was given intravenously to the mother throughout labor and then orally to the infant for 6 weeks. This was a very expensive and more difficult to do regimen. And it was interesting, the health ministers from the African countries said, we can't afford this, we can't do this, we need something else. And so the investigations that were done were saying, well, okay, well, what if we only give AZT for 4 weeks orally? You don't give it intrapartum, you just give it to the baby. Would this work? And so there was a placebo-controlled trial to do that. And the ministers of health all said that they felt that that was ethical. Again, there were a lot of controversies about these placebo-controlled trials, but they were actually really critical because they showed that even a short course of AZT given orally without the intravenous could reduce transmission, not by 70%, but by 50%. And that information became available within just a few years and was able to be implemented in countries, this short course AZT. We then also did a study that looked at giving just a single dose of nevirapine to the mother in labor and a single dose to the baby. That also was found to be 50% effective. And so that was a very exciting regimen that WHO then moved to recommend, but had the problem of inducing resistance. So then people combined AZT and single dose nevirapine together and found that to be highly effective. So that then became the standard regimen WHO recommended. And then subsequently we moved to 3 drugs as it was shown to be more effective. And I'll just talk about that in 1 second. Just want to say that then we needed to deal with the issue of breastfeeding. And in many African countries, what they did was they said that the mothers shouldn't breastfeed or they should formula feed or feed for a short period of time. And what you saw were lots of babies dying because they weren't getting appropriate nutrition. So we needed to be able to figure out, how can you prevent breast milk transmission? Can you prevent it by giving drug to the baby for a longer period of time? Can you prevent it by giving drug to the mother? And so studies moved to look at giving drugs to babies for 6 weeks, 6 months, 12 months, 18 months, very effective. Or giving drugs to the mother for similar time periods, also very effective. But in the middle of all of this, PEPFAR came. And PEPFAR was really critical. When was that? 2002, I think. Before then, treatment had very limited availability in Africa and many low and middle income countries. But with PEPFAR, treatment began to become available. And as time went on, treatment more than just AZT, combination drugs became available. So you were able to move from effective regimens to really highly effective regimens with the ability of PEPFAR to provide these drugs for the mothers. And I kind of lost track of what your question was, but that's the story of where we got to in terms of prevention of breast milk transmission and eventually moving to everybody should get treatment lifelong during pregnancy, before pregnancy, during breastfeeding, and that has effectively reduced transmission risk in women who are on these drugs and remain on the drugs and are suppressed to less than 1% from 40% in breastfeeding countries.
I think you answered it brilliantly, because it was the question about what did we do internationally to affect a change, and you brought it full circle. So I can't ask for any more. I know that Andy has a question.
I'm struck by all of the innovation and the response in all of this. And one of the things we work on here in the museum is to try to help people understand the way that AIDS changed the world in a bunch of different capacities. Just going back and doing some of the research on this, for example, the idea of universal precautions was really something we didn't talk about in healthcare the way that we do, that really became the standard of care and a normal thing in response to AIDS. And I'm wondering, as you look at this, where do you see other places that this has had an impact? Especially in the area of OBGYN and pediatrics. What have we learned from it, or what was the application around that? Because I'm really fascinated by the way that this all the response that we had so quickly, and are we learning anything from it? Because
yeah, it's interesting, the question on universal precautions. So when I trained, we didn't use gloves to draw blood. There weren't all of these universal precautions. HIV came around and people began to say, oh, that person has HIV, so we have to be really careful. And then we said, well, no, you actually don't know who has HIV, because you don't have to have symptoms to have HIV. And so you need to do this with everyone. And that kind of removes the stigma as well, so that it isn't that patient with HIV put in that room that you don't go in, but everybody gets treated. And so that moves to almost everything that we do today, which is universal. And also with HIV testing. So initially people said, well, pregnant women who are at risk of HIV, should get tested. And then individual physicians could say, well, that person is at risk, or this person is at risk, when actually they didn't know who was at risk. And so after the 076 trial, by 1995, we worked to develop guidelines that said every pregnant woman in the US needs to get tested during pregnancy for HIV. It isn't risk-based. And that's true for hepatitis B as well, that risk-based testing doesn't work. You need to do universal testing, and people need to know their status. And this then can translate to Africa, where all pregnant women should get tested. It isn't just, this particular type of woman, but all women should get tested. And so that's one important way, I think.
I think that's an incredible distinction about how testing in itself it has changed the landscape of identifying who is and who isn't positive, and allowed people to then take away that they can't visually see somebody and say they're positive or they've got AIDS. But I also think that there was a lot of backlash in even having a test. And you had alluded earlier that when the test became available, but when it first started, it wasn't for general population. It was really, if I understand it correctly, to test the blood supply. And that was controversial in itself, because I think of what you said is that if we test the population, what do we offer them?
Right. It's what do you do? And that becomes the key, both in terms of testing, but also in terms of stigma. So in the days when there were no treatment, nobody wanted to know if they were HIV infected, because they figured they were just going to die. Pregnant women, why should they know there was nothing they could do for their baby? But now there is. And so there's an important reason to get tested, because there's something to do. And something to do that makes you have a normal life, that makes you have a normal baby. And so that then also removes stigma from the test. And now not only does a test, if it's positive, give you life-saving treatment, but if it's negative and you're at risk, there's now things you can do to prevent that risk from happening. So finding out you're negative is as important as finding out if you're positive. And if you're having, if you're at risk, there's something that you can do to decrease that risk. And the cabotegravir studies that just became available, where they're giving, IM cabotegravir once every 2 months, it reduces the risk of HIV acquisition by 60% more than does the standard tenofovir FTCT pill, which reduces the risk extremely well, so that you now have very effective prevention measures that can be put into place.
That's a really striking thing that we try to educate people on. I think that because there's been a decent amount of press, we still need more about current PrEP availability. I think that people don't realize we've been doing PrEP from as soon as we figured out that we had a medication. We started thinking about this, we started thinking about post-exposure prophylaxis in healthcare with AZT immediately. So that was all there. There are so many things I want to talk to you about. And we, on our spotlights, we maybe should say, our mini spotlight, we get about a half an hour. So that went really quickly, but I feel like I would be remiss if I failed to point out, I'm looking at your magazine covers on your wall in the back.
Yes.
And if you look at behind Raquel, at the back of the museum, we have a similar collection.
Yep.
So tell us about those, how you chose those. And
yeah, so this was when I worked at NIH, and I can't stand empty walls, and so I would save all of my my meeting tags, etc. And I began to pick up on frames for work that I was doing. So you can see one is women in HIV. You can see pediatrics in HIV, sexual transmission in HIV. And in the middle of all of that, in the bottom middle, that's Elizabeth Glaser, who I actually met while she was alive back in 1995, when she began to work with Phil Pizzo to become an advocate for treatment of children. And so I actually worked with the Elizabeth Glaser Pediatric AIDS Foundation very early on. I used to do grant reviews for them and participate in scientific meetings. And she was quite an incredible person. Another person who could take adversity and convert that into something that makes a difference in people's lives. And she died. That was of course when she died. But I think she would be quite amazed if she looked at the Elizabeth Glaser Pediatric AIDS Foundation now, which provides more than 2 million tests for pregnant women so that they can be able to access drugs to prevent transmission to their children, which of course she couldn't do. And that has clinics all over the world that provide treatment for children, which of course her younger child, Ariel, couldn't have. That was her older child, Ariel, who died. But Jake, her younger child, who was infected in utero, he is alive and well and in his 30s and on combination treatment, and quite an amazing young man. And this was, I think, in part because of her strong advocacy to the world that money needed to go for treatment of children, for pregnant women. So I'm proud to say that I knew her then, and I'm proud to say that I now work with her foundation to try to implement some of the things that I worked on at NIH, having retired in 2014.
Does one ever retire from the passion of their life? I don't know.
No, I don't think so. My husband would definitely say I'm not retired.
So I want to end with the question, from your perspective, What else do you think is needed to end pediatric HIV?
Yeah,
That's a
so
loaded question, but it's a question that I'm sure everybody's looking for. How do we end the epidemic?
you have to look at how does transmission still occur? So the first way is that women continue to get infected, and those women get pregnant. So if you really want to end pediatric HIV, you really need to end HIV in women. That's the first thing, pregnant and breastfeeding women. The second thing is prevention of unwanted pregnancy, so that HIV infected women can decide when they want to get pregnant and make sure that they're on treatment and they're virally suppressed before they get pregnant. And just to comment, in non-breastfeeding countries, a woman who is on drugs prior to becoming pregnant and who is fully virally suppressed throughout her pregnancy, she has 0% risk of transmission. So in the case of a non-breastfeeding woman, U equals U if she's on and suppressed prior to pregnancy and throughout pregnancy, which is quite amazing. So prevent incident infection in women, prevent unwanted pregnancy, and then let's try to improve what drugs we have. The remaining reasons for continued transmission are either that women aren't on drugs at all, or they're on drugs and they stop them, particularly in the postnatal period. So why does that happen? Well, it happens maybe because treatment is complex or it has side effects. So if we can develop better drugs for pregnant women, safer drugs, easier to take drugs, maybe injectable drugs. We have a new drug, lenacapavir, which can be given subcutaneously once every 6 months. Maybe that is a way to go into low and middle income and high income countries. And then we need to be able to implement things better. We need to be able to improve maternal and child health care. We need to be able to get infant diagnosis better integrated in low and middle income countries. Only about 50% of babies of mothers who are HIV infected get tested. And, in order to be able to save their lives and treat them if they're infected, they have to get tested. And we need better treatment for children. And better ways to implement treatment. And so there's a move to move all children globally to dolutegravir, which is a highly effective drug with less side effects. And so that's a kind of long way around of answering your question, but those are the things that I think are needed.
I think it's a perfect answer because you integrated changes in society, as well as the implementation of biomedical interventions. And I think that they go hand in hand in order to make sure that this happens. And, people feeling empowered in their self to be able to stay on and maintain their viral suppression is important in all that we're talking about. Well, we have come to the end of yet another incredible Spotlight series, and I can't thank you enough, Dr. Mofenson, for letting us have this conversation and imparting the information of the wealth of information that you have. And I am honored to have been able to be here with you today, and hopefully in the future, we might have another opportunity to have a conversation. But we do these things at the World AIDS Museum for people to be able to hear incredible icons, is the word comes to mind, who have done the work in HIV from the beginning. And so I want you to stay tuned for our next installment of the World AIDS Museum and Educational Center's Spotlight series. Until next time, everyone.
Thank you.